key studies were presented discussing various aspects of adjuvant therapy for melanoma. Last year, Lex Egermont presented data from the EOITC 18071 trial, which evaluated the role of high-dose adjuvant in ipilimumab at 10 milligrams per kilogram. And although that trial showed a survival benefit, there was a lot of problems around toxicity. And I think although that treatment has been licensed in the US, there are a lot of concerns about safety associated with that regimen. The American Intergroup E1609 trial has looked at different doses of ipilimumab 3 milligrams per kilogram versus 10 milligrams per kilogram, and both those arms are also compared against a third arm, which is high-dose interferon, which is a well-established treatment in the US. So it's a 3-arm multicenter US trial. Because of the concerns about toxicity, it was agreed that they could release the data comparing the 3 versus 10 milligrams of ipilimumab early from a safety perspective. So that was the safety data that was presented at ASCO. And overall, it showed that the progression-free survival at the 2 arms was the same, but the 3 milligrams per kilogram dose was much safer. So many fewer serious adverse events occurred, and clearly a much more acceptable regimen to offer patients. So we need to wait for the long-term outcome of that trial, but we can be reassured that probably in the future 3 milligrams per kilogram is going to be a much better dose to work with. AVAST-M is a UK national trial that was recruited 1,343 patients between 2007 and 2012, at a time when there was a lot of interest in the role of angiogenesis inhibition. We know from the metastatic setting that bevacizumab, an antibody that blocks VEGF, has some activity in metastatic disease, and the question is whether or not that drug might be more effective in the adjuvant setting. So this trial compared adjuvant bevacizumab with an observation arm, and the interim analysis did show an improvement in disease-free interval. However, today the overall survival data was presented, which showed that there was no significant difference between the 2 arms. So bevacizumab is not going to be licensed and taken forward in the adjuvant setting. The trial did generate some interesting data around the genetic mutation status of patients recruited to that study. There was some suggestion that patients who have a BRAF mutation actually have a poorer survival in the observation arm of that study. And an exploratory piece of work was undertaken also to look at the role of circulating tumor DNA. And measuring circulating tumor DNA in the plasma of patients after their surgery appeared to predict for outcomes. So detection of ctDNA post-surgery predicted for poorer outcomes in terms of disease-free interval and overall survival. That was an exploratory piece of work, and I suspect that that is something that we do need to explore further in future studies. This is a French-led study taking forward a really difficult question about the role of adjuvant therapy in the context of resected uveal melanoma, a disease that we know is highly resistant to conventional treatment. And this trial recruited patients and compared adjuvant fotemustine to surveillance. They were picking out high-risk patients, and they did this by looking at both clinical and genomic factors. But even so, the trial was stopped early for futility, so there was no benefit from adjuvant fotemustine compared with observation. I think it just shows how difficult it is to find an active drug in this disease, where we still don't really have active drugs in metastatic uveal melanoma. We probably need to crack that issue before we look at further adjuvant studies. Right now, there are a number of adjuvant therapies that are licensed, particularly around the role of low and high dose interferon that is used variably across both Europe and the Western world, really. I think we don't really feel that that is going to be the future. the benefits are marginal and the toxicity is significant. We know that there are a number of key studies that are recruiting or have completed recruitment, but we're awaiting the outcomes of those studies, particularly around the modern checkpoint inhibitors, the anti-PD-1 antibodies, and also the MAP kinase inhibitors in the BRAF mutant population. So I suspect we will see in the coming years the results of these new trials that will probably replace the old interferon treatment that we have been using up until now.